Yeah, thank you. I feel quite nervous actually. I've got used to public speaking, but the speakers this morning have been so great and so inspiring. And thanks so much for having me. I've not been to Middlesbrough before. Love it. Great place. So this is the good news. We've spoken about this. Smoking rates have come down. We're all pleased about that. But as we know, there are disparities in who smokes. So it's the poorest people smoking. And traditionally, we've looked at this through social grade. So we can see here, this data is taken from the Smoking Toolkit study, that those people who are what we call in professional and managerial work are less likely to smoke, around 11%. And those people who are in lower paid work, which we call routine and manual work, are smoking at twice the rates. And that's been the traditional way that we look at health inequalities. But one of the streams of work that I focus on is how we can look at inequalities more broadly and do better to see where people are smoking and where we can target our very finite resources. So housing status. Okay, so we're in a housing crisis in the UK. Anybody that follows the Marmot reviews will see that that housing, and especially social housing, council housing, not that there's much council housing anymore, is associated with poor health, and smoking is one of the drivers for that poor health. And we see here that smoking rates are around 35% for people in social housing and much, much lower for people who own their own homes. So housing status is really a good proxy, an independent marker now for deprivation, and it's something that we should be looking at targeting resources. We know that mental ill health is also a way that we can look at inequalities. People with poor mental health, including serious psychiatric illnesses, are much more likely to smoke. As Anne said, they're much more likely to die younger, around 20 years younger, because of their smoking. But actually, even non-serious mental illnesses such as distress, so we measure in the Toolkit study past month distress, we can see that people who are experiencing distress are much more likely to smoke or have been a smoker, and people that are not reporting past month distress are less likely to have smoked or have quit smoking within for over a year. Now, I wouldn't want to say that's causal. What you could say is that people that are less stressed are much more likely to never smoke or be able to quit. But again, it helps us to see where we can target our resources. And in the toolkit, we're really lucky that we can look at the association of smoking with other health behaviours, namely alcohol. So this is a paper that was led by my colleague, Claire Garnett. And we wanted to look at, does smoking prevalence increase by your risk of alcohol dependence? And I was quite shocked. I knew there'd be a relationship. I didn't know it'd be as linear as this. But what we were able to show, that in people who are at risk of alcohol dependence, as measured by the audit score, their smoking prevalence rates for current smokers was 57.9%. And we saw a step change as people's risk of alcohol dependence went up, as did the smoking prevalence rate. And some of you will know, and if you don't, that if you smoke and drink, your risk of cancer increases. So again, we need to target resources. But an area of work that I'm really interested in is smoking amongst inclusion health groups. Okay, so that's people who are excluded from mainstream health services, people who overly rely on emergency services. This is people experiencing homelessness, who may or may not be dependent on drugs such as crack and heroin, vulnerable migrants. And we've plotted this data recently looking at smoking prevalence rates from 2006 to 2022. And you can see, so the one is 100, and it started at around 92%, and it's currently now about 72%-ish. So massively high smoking rates amongst these groups. The data's really poor. We don't routinely collect this data. But, as Hazel Cheeseman from Ash pointed out to me when I presented this to her, if that is a true decline, this is a picture of hope, because we have done very little to reduce smoking in these groups, very little targeted interventions. So if we did do something, we might see real change. Anne's already mentioned this, that we do have these huge disparities. We've got this 5% goal, and For people with a mental health condition, we're going to miss this by about 20 years. Going back to this slide, we did some really crude analysis to look at what that would look like, and it's more like 75 years. So smoking is becoming a real behavioural marker for deprivation. So what are the common reasons? I was asked to talk about the common reasons that people in these groups smoke. It's the same reasons that everybody smokes. But there are probably unique reasons why people continue smoking within these groups, such as the reasons why people start smoking are often the reasons they continue smoking. But for this group, there are these other factors, such as trying to deal with cravings and withdrawals when you're living in a stressful environment, when you're trying to feed the children, when your benefits are not going in, when you're not sure if you can get to work, when you're having to get a payday loan. That's really hard. Boredom. Smoking marks time for so many people. And if you don't have access to green space, if you can't just join a club, people say, go and join a gym. If you haven't got the money to join a gym, it's really difficult, it's tough. But the big things, and that's why they're in red, is we're just not offering enough support to quit, and there is a lack of opportunity for people to quit within these groups. And this is just a snapshot of studies that I've been involved in and from other people. This is a shame, because across studies, across these groups, we see that motivation to quit is similar to people that don't have these health and social needs. Their past year serious quit attempts are around the same as people that don't have these needs. And there is some use, depends where you look, of evidence-based support. People are accessing their GPs, but the big difference is a lack of sustained quit attempts. So when we say these groups are hard to reach, I don't buy it. I don't buy it. There's something else is going on. So this is something that I developed, this behaviour change pyramid, and this is how I read the evidence of what's going on. The more health and social needs people have, the lower we see their ability to change, therefore the lower their priority of smoking cessation. Smoking's always put on the back burner. We need to get them housing, we need to sort their benefits, and therefore the opportunity to change becomes narrower, and that's the problem that we have. And this is a real shame as well, for many reasons, because we know that smoking is terrible for your physical health, but it's also really bad for your mental health. And we know that even for people with serious psychiatric illness, stopping smoking can improve your symptoms of stress, positive affect and mental well-being. And this has come from 2 Cochrane reviews now. So we do have some campaigns for the improvements that can be made to smoking, to mental health when you quit smoking, but actually I don't think that we have enough. And a real motivator for people in this group who already might have poor health from other things is you could improve your mental health, your mental well-being. And for some people, people who are especially poor, such as the groups that I work with, people who are using other drugs, people who don't have a lot of money or are homeless, when we offer them support, we see reductions in risky smoking practices. And I wrote about this quite a lot during COVID because it was something we wanted to stop people doing. We didn't want people sharing cigarettes. We didn't want people picking up discarded cigarette ends. And we do see that if we offer people support, while they might not quit straight away, what they do is stop these risky smoking practices. They stop or they reduce them. But these are not conversations that we're used to having with people, and maybe we need to. So what works? I've been asked to talk about what works, and I'm going to go through some of the things that we found in our work. I can't go through specific studies. I can answer questions on that. But basically, taking a harm reduction approach, things that we know have worked in drug harm reduction or sex harm reduction, and just applying that lens to tobacco harm reduction. So first of all, integrated care, and this goes back to my point about hard to reach. People are not hard to reach if you integrate the care within the backdrop of other types of support. So whether it be the food banks could work. We don't have evidence of that. Martin and I have tried. It didn't work. But anyway, it didn't work because they didn't let us in, not because it didn't work, I should say. Housing estates, safer injecting provision. If you offer support there, people will, you're already there, you have a captive audience. If you ask people to go to the Stop Smoking service, it's unlikely to happen. We need to be integrating it in. Place-based, easily accessible. It is hard work to be poor in the UK. You are asked to go to so many appointments, and then if you give somebody an appointment for the Stop Smoking service, it's another appointment. People also want their care from familiar faces, someone who's already given them support for something else. They don't want to tell their life story again. We need to make it easy for them, and we need to make it as accessible and friendly as possible. Staff training has been key. Now, for anybody that has access to a third sector, my tip of the day, go and train the people in that third sector and give the staff a certificate. They have no money for staff training. So if you can go in and train them in Stop Smoking and give them a certificate and upskill their staff, they will thank you, and you will be able to get a really good foundation for a relationship. That's my tip of the day. We've done it, it works. And I should say, big shout out to the NCSCT who've developed this video, stars me and Louise Ross, if you know her, and Debbie Robson from King's, specialist training, VBA Plus for people accessing homeless services. But although it's about homeless services, I think this video can be used across, you can take so much out of it for offering support across a whole range of environments. Types of support. Nicotine is greater than behavioural support alone. We know this, it's no different for this group. Behavioural support in one form is greater than no support or minimal support. And what do I mean by that? Well, some studies have shown that if you can offer people face-to-face support plus a telephone call or a text message, then that's better than just one type of behavioural support, and definitely better than no support at all. E-cigarettes are a preferred choice, but people need help. For people that are quite cognitively impaired, they need simple devices, they need help with recharging them, they need to have, just daily problems be able to be fixed, and they need to be able to swap things around. People worry that they're using their vape too much, so they need nicotine education. They say, I'm using my vape more than I smoke, does that mean I'm more addicted? So we need to let people know that actually it's because it takes longer to get nicotine into your blood through the device you're using. And more choice. So traditionally, we give people something and then they might come back within a few weeks. With these people, sometimes you need to be swapping things around much more quickly to keep them interested, to keep them motivated. And also, people are going to be more heavily nicotine dependent than people might be used to. So more than one, there is some evidence for combined nicotine products, such as a patch and a vape. But again, it's that nicotine education. The goal is to actually stop smoking. The goal isn't to worry at the moment about how much nicotine you're using. And also people's goals, what they've told us through our work, is that they want their goals to be related to reduction and the reduction of these unpleasant behaviours, such as my goal might be that over the weekend I don't have to pick up discarded cigarettes. My goal over the weekend might be that I don't have to go without eating, so I can buy, because I'm buying tobacco. So, I can't believe I'm on time. That never happens. So smoking is dangerous to all people and exacerbates health inequalities. Integrating an evidence-based approach into broader social care and harm reduction agendas shows signs of promise, but doing nothing maintains the status quo. And I'd just like to thank these stellar humans who make my work. That's us, that's the Utah group there, who just make all this work possible and bring this data to us to be able to create these thoughts and thinking. And to my collaborators, Debbie Robson, Lynn Dawkins, Dorothy Vlad, and everybody else. Thank you.